Good afternoon, everyone, and welcome to the award ceremony and the academic presentation of the 2024 Anne and Neil McArthur Research Award. And I thank Anne, being the granddaughter, for being here with us as well. And Sarah will introduce Anne in a few minutes. My name is Lahana Tabani. For those who may not know me, I wear quite a number of hats. I'm a professor at McMaster, but I'm also the Vice President of Research here at St. Joe's Hamilton. And my role has just been recently expanded to cover the entire system. So I'm the VP Research for the system as well. We are incredibly honored to have Dr. Mark Loeb. Mark is not only an excellent scientist, but he's a fantastic colleague to work with. I've had the privilege and the honor of working with him over the years, and we're delighted to have him here as one of the recipients for this award for this year. His research is focused on the epidemiology of infectious diseases, including the transmission and control of respiratory infections like influenza, West Nile, COVID-19, and dengue, right? Some people don't know dengue is another one of those diseases that kill people. Through his valuable insights into vaccine efficacy, Dr. Loeb's work has helped shape public health policies and strategies for managing spread of infectious diseases. We depended on people like Mark during COVID-19 when the rest of the world was actually struggling to figure out what to do. Mark was one of the people in the forefront of trying to find the solution to COVID-19 and certainly advising us how to behave to protect ourselves from the virus. Following the presentation, I do invite you to join us in the lobby for a special reception and refreshments. But before we begin, let's take a moment to reflect on the lens on which we are privileged to serve our community. We at St. Joe's Healthcare Hamilton recognize that the lens on which we provide care, learn, and conduct research are the traditional territories of the Mississauga and the Haudenosaunee peoples. For thousands of years, the first people sought to steward the precious resources and share this land with others. These territories are the subject of the Dish with One Spoon, One Pen Belt Agreement. This is an agreement between nations to peacefully share and care for the lands around the Great Lakes. At St. Joseph's Healthcare Hamilton, we do pledge to continue to work together with our indigenous peoples in building a more just society where their gifts and those of other people are nurtured and honored. Honored guests, please welcome Ms. Sarah Feliz, President and CEO of the St. Joe's Healthcare Foundation, to introduce the award and the McArthur family. Sarah.
Well, good afternoon, everyone. On behalf of St. Joseph's Healthcare Foundation, I'd like to start just by thanking the St. Joe's Research Institute for coordinating the Anne and Neil McArthur Research Award selection and today's event. The prestigious Anne and Neil McArthur Award was funded through an endowment in 1999 by the McArthur family to recognize an internationally renowned Canadian researcher whose area of study is also a focus of research at St. Joe's. Anne and Neil McArthur knew the transformational power of research to advance healthcare innovation and change the landscape of patient care. And this award recognizes the achievements of the recipient as a world-renowned researcher in this field. So on behalf of all of us, I would like to thank the McArthur family for their continued support of research at St. Joe's. As an academic health sciences center, we're grateful to have so many outstanding researchers who are truly leaders in their fields. And we are proud to acknowledge all the recipients of the Anne and Neil McArthur Award, whose portraits are prominently on display in the hallway just outside the auditorium. This award is a testament to their dedication to and excellence in leading groundbreaking research that ultimately improves the lives of those in our local community, across Canada, and throughout the world. And we are delighted to have Anne, the granddaughter of Anne and Neil McArthur, who is able to join us once again for this year's award presentation. And please join me in welcoming Anne to say a few words and introduce our award winner.
Thank you. And I'm actually really appreciative of that timeline because I was trying to think back. And so that would mean that I started coming to these awards actually when I was in elementary school. And to think of how many years that it's been continuing on and, the great recipients that we've had and presentations that we've seen over the years. It's really an honor, as much as I think my dad has started to find himself making himself busy so that he could pass it on to his children. It really is an honor to be able to be here today and to introduce the recipient of this year's Anne and Neil McArthur Research Award to Dr. Mark Loeb. My grandparents, Anne and Neil McArthur, established this endowment fund to support research. And then there's a recognize that the power of research to advance healthcare innovation and to make lasting impacts on our patients' lives and communities. It celebrates the achievement of researchers recognizing the international community for their work and whose field of research is a focus of St. Joseph's Healthcare Hamilton and the Research Institute of St. Joe's. Dr. Loeb, this year's very worthy recipient, is a staff physician in the Department of Laboratory Medicine at St. Joseph's Hamilton Healthcare Hamilton. He serves as a medical microbiologist and infectious disease consultant within Hamilton Health Sciences. A professor in the departments of pathology and molecular medicine and health research methods, evidence, and impact at McMaster University, Dr. Loeb also holds the Canada Research Chair in Infectious Diseases and was the co-director of McMaster World Health Organization's Collaborating Center on Infectious Diseases. For nearly 30 years, Dr. Loeb has been one of the leading experts on infectious disease in Canada, specifically related to viral illness, immunization, and more recently, defining best practices at a therapeutic and preventative level during the COVID-19 pandemic. His research interests include clinical trials on influenza and other respiratory infections, population-based studies on West Nile and Dengue, and infections in the elderly. He has co-authored over 400 peer-reviewed publications and has been cited nearly 48,000 times, leading to significant contribution to the study and understanding of infectious disease. Dr. Loeb, among his many distinctions, was recognized as a Fellow of the Infectious Disease Society of America, one of the highest honors in the field of infectious disease, and as a Fellow in the Royal Society of Canada, the highest honor received in the arts, humanities, and social sciences. I am pleased to present Dr. Loeb with the Anne and Neil McArthur Research Award and look forward to today's very relevant and poignant presentation. Dr. Loeb.
Thank you. Thank you very much for the kind introduction. Thank you, Lahana. So I'd like to thank the organizing committee and in particular the McArthur family for their generosity and support of research. So I'm going to talk about randomized trials of influenza vaccination and herd immunity. So you might have heard the term herd immunity recently with respect to measles, the fact that you need high uptake of vaccination in the population to stop a virus or other pathogen from spreading. So this is the same concept, except we're not talking about measles, we're talking about influenza. And it's in a sort of a special sort of community where we've been doing randomized controlled trials of influenza vaccination. So I'm going to go through those trials and how they worked in a very, very special community. So many of you are aware that that influenza leads to a tremendous burden. In fact, every year, influenza epidemics cause up to 1 billion cases of the flu. And up to 5 million of these cases are very severe complications, mainly hospitalization, pneumonia, and unfortunately sometimes death. And it's estimated that there are about 600, up to 650 deaths worldwide due to influenza. So it's truly a leading cause of vaccine-preventable death. This is a slide of an earlier study. There was a series of studies in the 1980s by Dr. Arnold Monto and his group looking at how the virus influenza spreads in the community. So on the left-hand side, you could see a figure where these are attack rates based on antibodies showing really high attack rates in children. So if you look at the bar diagram, children between the ages of 0 to 4 and 5 to 9 tend to have in the community high attack rates of influenza. They tend to be infected. They also tend to be infected early on, and our studies and studies of others show that they shed the virus longer. Okay, so they're an important source of transmitting influenza to other people. On the right side, in the middle figure, you'll see the hospitalization. So that occurs at the extremes of age. So the very young and the very old are more likely to get hospitalized due to influenza. And we see that with other infections like Streptococcus pneumonia, group A strep. And deaths, though, occur mainly in older individuals. So people over the age of 65 are more likely to die of influenza. So anything that we can do to protect those vulnerable people from the complications of influenza is really important. So the rationale for this program of research was that healthy children are felt and were felt at the time when we were designing these trials to be a really important source of community transmission of influenza. And vaccinating school children had been proposed as a strategy to protect high-risk individuals. And there have been some observational data to support the benefit of this strategy. And this was one study. This was a study done by Tom Reichart and colleagues, where they looked at the program that was developed in Japan. In Japan, in the late 1950s, they decided to selectively vaccinate school children. Okay, so Tom Reichart looked at this data, and he looked at the effect of vaccinating school children in Japan using the United States as a comparator, where they never did this. And he looked at the reduction in excess pneumonia and influenza deaths in older adults. And as you could see, when Japan introduced this policy, the rates of excess pneumonia and influenza deaths plummeted in older adults. In the 1990s, the government of Japan said, you know, this is a bit too expensive, so let's stop this program. And when they did that, as you could see on the right-hand side of that first figure, the excess deaths and pneumonia in older adults tended to increase. Okay, so this was observational study. It wasn't a randomized controlled trial, but it was suggestive that there's something important about trying to vaccinate children, young children. And Tom Reichart, by the way, is a very interesting person because he started his life as a biophysicist, and but then he wanted to contribute more to society, and he realized he didn't have a lot of a clinical background, so he decided to go to medical school. And he went all through medical school. He became a clinical oncologist, and then he worked for Becton Dickinson. He became actually quite wealthy. He had a bunch of companies, and in about the year 2000, he said, "Okay, I'm gonna stop working, and I'm gonna devote my life to answering a question." And the question was, why do older people tend to die more in the winter? And this was one of the studies he did. So it was a fascinating series of modeling studies from Tom Reichart. And so the idea of vaccinating children selectively is not only important for seasonal influenza, but it's also important for pandemic strategy. So this is the traditional priority of who gets vaccinated during a pandemic. First, it's healthcare workers, public health workers, essential service providers, people at high risk for complications, healthy adults, and the very bottom is healthy children. So when we were designing these, we thought, well, if young children are spreading the virus, why don't we just vaccinate them selectively and actually try to reduce the transmission in the first place? So that was part of the rationale for this program of research. And there were a lot of limitations of existing studies. There were no randomized controlled trials of indirect benefit to the community. There were observational studies done in Michigan, Japan, and Texas, but they were subject to bias. There was one school-based trial of live attenuated vaccine. It wasn't a blinded study. It wasn't actually a randomized trial either. And there was also a lack of comprehensive lab data. So we said to ourselves, we should do a study on this. We should really try to do a study where we go to cities or small villages and vaccinate children and see what happens in the whole community, but do it in a randomized manner. And it was obvious that we couldn't do it in Hamilton, Mississauga, Toronto. The population is so dense. So we said, okay, well, let's go to somewhere more rural. Let's go to the prairies. Let's go to Saskatchewan, where there's these little towns, little villages. and let's see if we can, create a randomized controlled trial there. So we got Excel files, and I just remember this very clearly. We got towns of 500, 1,000, 10,000 in Saskatchewan. We looked at all the schools, and laid it out, and then sort of developed a template for a randomized controlled trial. The problem was, though, when we did this, the trial would cost like $65 million to do, because it would just be, going to a town of 10,000 and getting research nurses to do active surveillance just wasn't feasible. But the thing was, when we were looking at the schools, we found some of these schools were Hutterite schools. And we said, oh, okay, what's that? What's a Hutterite school? Well, the Hutterites are, they're Anabaptists. They made their way from Europe to North America around the time of the First World War. They're pacifists. And so most of them, they had immigrated to the United States and said, well, we're going to go to Canada. So it so happens that 75% of Hutterites in the world live in Alberta, Saskatchewan, and Manitoba. So we started recognizing that the Hutterites live on these, they don't live in large towns, they live on these colonies of about 80 to 120 people. And when the colonies get too large, they literally draw straws and split and become another colony. So we thought, well, that's it. We can't do this in typical cities, but we can do it perhaps in Hutterite colonies. It would be, a proof of principle of vaccination. So we were happy with that, but then we had to get the Hutterites to agree. And there are different Hutterites. There's Lederlites, Schmiedelites, and Darcelites. So I first approached the head Lederlite, and he was a gentleman. It went in sort of it went by age, so he was an older person in terms of a senior elder person, and he didn't like the idea. I spoke to him by phone, and then a week later I got a note, faxed to me, handwritten, said, no, we're not into that. So we thought, oh, that's too bad, we can't do the study. But then one of our colleagues in Saskatchewan, who was a medical officer of health, said, okay, well, that was a Lederlite. Why don't we talk to the Darcelites? Okay, so I picked up the phone and I made my call to the head Darcelite person. And unfortunately for him, he was really hard of hearing, so he didn't know what I was talking about. Fortunately for us, he put me in contact with Reverend John Stahl, who was the second in command. And that was it. John Stahl was, understood exactly what we wanted to do and said, well, how many colonies do you need, Mark? I said, oh, we'll take 10. So we got 10 colonies and we started a pilot study. We got funded by the NIH to do, because CHR wouldn't fund it at that point. So we got funded by NIH just to show proof of principle. And eventually we were able to, to expand and do a randomized controlled trial in the Hutterite colonies. So the first trial we did was to test whether vaccinating children in Hutterite colonies with an activated influenza vaccine could prevent lab-confirmed influenza in other community members. So again, the target population wasn't the kids who were getting vaccinated, it was those individuals who were not vaccinated, which was the majority of the people in the colony. And our hypothesis was that if there was over 70% uptake of these healthy children in the intervention colonies, it would reduce lab-confirmed influenza indirectly, okay, in those people who never received the vaccine. So we did that. This is a map of the distribution of Hutterite colonies in Alberta, Saskatchewan, and Manitoba. So it was sort of across the prairies we were doing this. And I recall one time in Portage-la Prairie, we had one of our initial meetings with the Hutterites, and it was at this place. It was strange. It was like a hotel, motel. It had 3 skating rinks and a curling rink. And I went in and I said, we're going to have a meeting, with our Hutterite community, and the person at the desk said, no, just keep talking, you're on film. I said, what? They were filming a movie at the same time. And then some of our Hutterite participants started coming in and they thought they were part of the film set. So I had to run to the parking lot and said, okay, in the back. So it was a sort of close call because we wanted to give a good impression to the Hutterites. So it was a strange episode. So there were a lot of things like that happened over the years. The study design was a blinded, stratified, cluster randomized clinical trial. So the colonies were randomized 1-to-1, either to get influenza vaccine or hepatitis A vaccine. Again, it's the children that are getting this. Allocation was done after enrollment to reduce selection bias. And it was healthy children between the ages of 36 months and 15 years. That's because in Hutterite colonies, that's when they go to school. So they received an inactivated vaccine, which is the Vaxigroup vaccine, or a pediatric hepatitis A vaccine. And we selected hepatitis A vaccine because there had been some outbreaks of hepatitis A on the colonies. So that was the intervention group. The group that was really the target group for the primary outcome were the other colony members who were enrolled to assess the indirect benefit. So the primary outcome was RT-PCR confirmed symptomatic influenza. Our research nurses did surveillance twice weekly. We also looked at other outcomes like visits to the physician for acute respiratory illness, influenza-like illness, absenteeism, antimicrobial prescriptions, hospitalizations for pneumonia, deaths, and we did antibodies. We did HAI titers before and after the influenza season. And I won't go into all the details of the analysis, but we had planned it to demonstrate a 50% risk reduction. So this slide is a flow diagram. We'd approach 187 colonies. 138 were excluded. Some were ineligible. Some were too remote geographically. We had to keep it close, at least relatively close to major city, or not major cities, but some sort of cities. And some were against the influenza vaccination. Some, weren't just interested. So we ended up with 49 colonies randomized, 25 randomized to the influenza vaccine, 24 to hepatitis A, and overall over 1,700 were included in the primary analysis in the influenza group, 1,500 in the hepatitis A group. This is the characteristics of those study participants. You could see it was a relatively young average age, around 26. You see the distribution of the age. So really about 30% of the population here was relatively young, a lot of children. About roughly 10% had been previously vaccinated against influenza, and relatively few coexisting conditions. This is characteristics of the clusters. So as I'd mentioned, there were about 87 in one group, an average size of 77 in the other, and a majority of the participants were enrolled, and the rest of the slide just shows the breakdown by age. So this was our main finding, that the effect of basically vaccinating those children had a dramatic impact in providing indirect protection. So the protective effectiveness was 61%, again, in those that never received the vaccine, but were just residing in a colony where those young children had been vaccinated, okay? And when you look at systematic reviews and meta-analysis, that's the figure that's usually shown for direct protection. How someone asks you, well, how good does an influenza vaccine work? It's about 60% effective, okay? And so we were able to demonstrate this, again, with indirect protection. So that's very important demonstration of herd effect. And whether we adjusted for individuals who had previously received a vaccine or not, it didn't really make a difference. And when we looked at the total protection, this was the effect of vaccinating the children along with the indirect protection. So this was the overall community protection. The overall effect was about roughly 60% as well. So similar type of thing. Our secondary outcomes, not all of them were significant, but they all went in the right direction. That is, there was reduction in antibiotic prescriptions, doctor's visits, influenza-like illness, and absenteeism. So really, it was sort of, to us, it was really dramatic proof of a herd effect. And the way this worked was that the receipt of the influenza vaccine just stopped outbreaks. So there was a reduction in outbreaks compared to those colonies that had the hepatitis A vaccine. So this study was influential in changing policy. The ACIP in the United States, which is more or less run by the CDC, used our data to actually make a policy of preferentially vaccinating healthy children. Okay, prior to doing this trial, healthy children were not vaccinated against influenza. So the policy was changed in the US, in Canada, in Australia, and other countries as well. And it was named as Lancet Paper of the Year. So it was a successful trial. And so, you know, around, this was 2007, around the time that we were doing the trial, there was a study that compared the live attenuated vaccine to an activated influenza vaccine in infants and young children. So this is a nasal spray. And their data, which is individually randomized controlled trial, suggested that the live vaccine was substantially better at protecting children. So we said, okay, why don't we repeat the study comparing live vaccine to an activated vaccine? So it was the same idea, really to test whether the live vaccine would further reduce lab-confirmed influenza, with a similar hypothesis that if we had 70% or more uptake of the vaccine, of the live vaccine in the intervention colonies, that would reduce the lab-confirmed influenza by 50%. So the way we did it, all of these studies were blinded. So we had to blind the participants. So the children that got the intranasal vaccine would get a sterile saline vaccine in the arm, and those that got the actual injection of influenza vaccine in the arm got sterile saline in the nose. So everything was mimicked. Everything was blinded. And this is the flow diagram. We originally looked at 228 colonies, but then went down to about 48 who were enrolled, 25 in the live vaccine arm, 23 in the inactivated vaccine, and overall there were around roughly over 2,300 participants in each group. And in this time, we were looking at the overall effect. So we weren't just looking at the indirect effect. We wanted to look at the overall community effect to see if there was going to be a difference. And this was actually quite important because the United States at that point had been using the live vaccine. They were using a quadrivalent formulation, and it just wasn't working. So they were they had basically said that, you know, the live vaccine would be no longer recommended. And what we found was no difference. So we found a hazard ratio of 1.03, confidence intervals ranging from 0.85 to 1.24. And it was published in the Annals of Internal Medicine. And, you know, at one point I said to the editors, look, you know, CDC is making these recommendations. You guys got to get this out there. So they did, but it was several weeks after. I don't know that it would have changed the policy. But it was, you know, different than the experience, the observational studies in the U.S. But it was not done on U.S. soil, which was, you know, I think a problem for the CDC. But studies, observational studies in Finland, observational studies actually in British Columbia showed the same thing. So interesting. So the third study was, again, a sort of similar comparison. This is of an adjuvanted vaccine. So an adjuvant vaccine is an influenza vaccine that has a molecule to stimulate the immune system to produce an immune response. So there had been an adjuvanted vaccine, you know, a head-to-head comparison to an activated vaccine that seemed to do better in very, very young children. So we said, okay, let's do this again. We'll compare the adjuvanted vaccine to a quadrivalent vaccine with similar hypothesis that this adjuvanted vaccine would be better. So we used the same method of randomization, but this time we were looking at very young children between the ages of 6 months to 6 years, and we did this over a 3-year time period. And overall, we had 20 randomized to the adjuvant, 22 to the quadrivalent vaccine. There were, you know, 771 versus around 900 in this population. So very much a smaller trial. And in effect, overall, we didn't really see a difference in the community effect, the hazard ratio of 0.78, with very wide confidence intervals. But what we did find was a substantial effect of the adjuvanted vaccine on influenza A. Overall, about an 80% risk reduction. So very strong effect of this adjuvant compared to an activated vaccine on reducing influenza A in very young children. So the conclusions of this series of studies was that herd effect can be demonstrated in settings where there's high enough uptake of influenza. Live vaccine achieves a similar level of community protection. And I think we demonstrated that cluster randomized controlled trials are a rigorous way to study herd effect. And along the way, we've done a number of observational studies. This is a study on viral shedding. At the time, there had been transmission from challenge studies. So challenge studies are human challenge studies where you have someone in a lab and they're artificially inoculated. And the problem with those studies is there have been few, they were all adults, very few children, very far artificially screened people for pre-existing immunity. So there were very few field studies of viral shedding. So we decided to do this in our Hutterite colonies. We looked at 10 colonies. We did this over a 3-year period. And what would happen is if someone was infected with influenza, we'd continue to swab them daily for 7 days, and then every 2 days for up to 8 weeks. And if there was an outbreak, we'd get everybody in the colony. So if they were asymptomatic, it didn't matter. We'd do daily swabs for a week, then every second day for up to 3 weeks. And this is just an epidemic curve looking at the types of viruses. So in red, seasonal H1, in blue, B, in green, H3, and in orange, the pandemic strain of H1. And what we demonstrated by doing this is if you look at the first column and the third column, it's H1N1 and the pandemic H1N1. And we looked at viral load with respect to what happens with onset of acute respiratory infection. And we found that with the H1s, whether it was seasonal or pandemic, the peak viral load coincided with the onset of acute respiratory infection. Whereas H3, in contrast, there tended to be a lag, of a few days. And we looked, we looked at asymptomatic infection and asymptomatic shedding, which we found in about 8% of the population. And we also found, as other people had demonstrated previously, that children tend to shed the virus for longer. So over the years, we've done a number of studies looking at the role of influenza HAI antibodies as a vaccine mediator in children, showing that for different strains, it varies a little bit. For some strains, the HAI doesn't actually always capture the effect of the vaccine. You need to use neutralizing antibodies. We've looked at adjuvant attenuated symptom severity of influenza infection. Again, for influenza A, it works very well. And we've looked at seasonal influenza vaccination severity in children who were vaccinated with either the live or the inactivated vaccine, showing that the live vaccine tends to do a better job at reducing severity than the inactivated vaccine. And more recently, we've looked at the HAI antibodies, just demonstrating the relationship for various strains in terms of their ability to actually reduce the risk of influenza infection. And more recently, we've been doing a cohort study over the pandemic. Unfortunately, the Hutterites were, great with our influenza vaccine, but they did not like the mRNA vaccine. So for, over the pandemic, the vast majority of members of the Hutterite colonies, they were not vaccinated with the mRNA vaccine against SARS-CoV-2. So we were able to follow the cohort and measure the effect of baseline immune antibodies, so looking at IgG antibodies and the risk of subsequent infection. So we looked at a subset of our Hutterite colonies and looked at two outcomes, either getting SARS by PCR, binary outcome, or a symptom severity score ranging going from negligible to severe infection. And this was the baseline characteristics of this cohort. It was 745 who never developed infection, 331 that did. Otherwise, the characteristics were pretty similar. And we found a very high attack rate. About 30% of individuals in these colonies were infected again with SARS-CoV-2. And what we found was when we looked at baseline antibodies, as would be expected, the baseline IgG antibodies were higher in those that were non-infected. So they were protective, and it was similar when we looked at the effect by severity. Those who were non-infected had higher antibodies, and when we quantified this in multivariable analysis, it was the effect of IgG antibodies, roughly 40% risk reduction, and previous infection in the past 6 months was very protective, about a 70% reduction. That was for the binary outcome of getting SARS-CoV-2 or not, and it was very, very similar for the prediction of severity. So again, IgG antibodies and previous infection was very, very protective. So to conclude from that cohort, that is that IgG antibodies and previous infection are associated with reduced SARS-CoV-2 infection. This was done over the Omicron period. So just to wrap up, this is a slide just summarizing our co-investigators, Dr. Margaret Russell, who's was instrumental. She's recently retired, and Dr. Angel Chu has taken her place. Kevin Fonseca at the Alberta Precision Lab, which used to be known as the Alberta Provincial Lab. At McMaster, we had Dr. Matt Miller. We have Stephen Walter should be at McMaster as well. It's a typo, sorry about that. Sorry, Steve. And Eleanor Pullingham at the Hospital for Sick Children, and more recently, Mark Lipsitch at the Harvard School of Public Health. We've been doing collaboration. So I'd like to acknowledge all our Hutterite colonies in Alberta, Saskatchewan, and Manitoba, and our sort of core group of Carolyn Kelly, Pardeep Singh, Amy Bartholomew, and Carla Coakley, who are working on the Hutterite projects. And below is our list of funders. Thank you very much.
Fantastic. We have time for questions. And Laura has a microphone. Laura,
Who had a question? Oh.
Thank you, Mark. That was amazing. One curiosity I have, I mean, we used to know that, the live vaccines are generally better in establishing herd immunity because of the possibility of the shedding of the live virus probably to the community or something. But I guess it was a little different in your study. Do you have any explanation about it?
Yeah, no, it's a really good point, because if you think of shedding of live virus and as to establish herd immunity, because you could think of it almost as you infect someone with a live virus, but if it sheds and infects someone else. So that's a good point. And we actually looked at that, and we thought, can we identify the virus strain? And we didn't find a lot of it. So unlike oral polio, where this is that's the mechanism, we didn't find that. That's a good point.
I'm not too familiar. Activated. Adjuvant. I just want to know.
Okay, so the question is about the types of vaccines, about what's the difference between inactivated vaccines, live vaccines, and adjuvanted vaccines. So inactivated vaccines are vaccines which, they don't themselves replicate. So they're basically they're basically vaccines that have an antigen. They're basically now they're sort of split virus vaccines. The advantage to them is that there's some contraindications in people who have a live vaccine that don't apply to the inactivated vaccine. So with a live vaccine, the advantage is that it actually mimics an actual infection. So there's T-cell immunity that could be boosted. The live virus will do that. The problem with the live vaccine is there are certainly certain contraindications generally in individuals who can't receive the live virus, or if they are immunocompromised, and in the particular type of live attenuated virus, people with very severe uncontrolled asthma should not be taking it. In terms of the adjuvanted vaccine, there's not really, the main drawback is what we call reactogenicity. So because it stimulates the immune system, people might have higher side effects. So the rate of having a sore arm or a red arm will be higher generally with an adjuvanted vaccine. So those are the major differences and the pros and the cons. Welcome. Okay. Yeah.
No, still not working. Okay, I'll shout.
Okay.
Mark, thanks for having us. It's been a real pleasure to work with you. According to terminology experts, I learned about epidemics as a mathematical model. The term herd immunity referred to that as the epidemic progressed, have more and more people who had acquired immunity having the disease.
Right.
And then there weren't very many people left, residual of the population, and that was herd immunity. It wasn't enough the other people to spread the disease anymore. But you're using it slightly differently. You have an intervention, which is vaccination. And I'm just wondering here, because the vaccination is never 100% effective, is there any distinction, discipline about how that term is used?
Yeah, no, it's a good point. It's a good point because the original definition was, as you say, was basically the uncontrolled spread of a virus or a pathogen, creating immunity, and it's been, I guess it's been borrowed by the vaccinologists, because it's the similar sort of thing that if you vaccinate someone, you'll if the vaccine can create protection, immune protection. So it's the same thing. I'll have to look up whether there's been, I haven't seen a paper that clearly talks about this distinction, but in the world of vaccinology, people talk about it all the time, right? About, can we create, herd immunity through vaccination? And that was often talked about, but it is a distinction. I guess you can argue as well that when a virus spreads through a population and infects some people may never, even though they're exposed, they might actually even never generate an effective immune response. So it's very, very similar. So in that vein, there are similarities, but it's a good point. The other point is that, there's the term herd immunity, but some people prefer to use herd effect, so there's that differentiation. And I think herd effect might apply more to vaccination.
I remember talking with you many years ago about, a small number that are asymptomatic either before they got, and from an infection control point of view, we sometimes, because of COVID, swab a whole ward, not thinking that we actually don't usually look for asymptomatic flu. We really only look for symptomatic flu. Yeah. In any of your studies, do you think asymptomatic flu can be a source of transmission? And, will there be sequelae of this if we ever do have another flu pandemic? Yeah, no, it's a really good question. And we've tried to look at that. And it's just that because the clinical trials we don't always
test individuals who have no symptoms. It was just that one cohort that I described. We tried to look for transmission, and it was just too difficult to delineate it. It's very difficult to make a judgment as to who gives the the virus to another one. What we're doing now is we're looking. It's actually a Bachelor of Health Sciences student working. I've got a whole bunch of Bachelor of Health Sciences students so working on secondary transmission in households, because we never looked at that. So we have all the households, and they're looking at, well, what happens when someone's vaccinated and not vaccinated in terms of transmission, and we might be able to go and look at that because we have antibodies. Actually, that's a good idea, because we have antibodies on all of them. So we might be able to see if there were, some of them had no symptoms, but they had a fourfold rise at the end. And, we could say, well, that's an asymptomatic infected individual. Did they potentially give it to another household member? If you're interested, we could join the group. We've just been working on it with the Bachelor of Health Science, so it's very interesting. Thank you.
If you did you start the vaccinations at the level of child vaccination? Did you in the age group?
Yeah, no, that's a really good question. It was very difficult because, we had to organize how we're going to vaccinate the children. So most of the children were vaccinated between the ages of 3.5 and 15. And it was a little too disruptive to take them out of school. So we had, planned, later in the day when they were there with their families outside of the school setting is when they get vaccinated. Now, I have been involved with a school study where with Dr. Jeff Kwong from the University of Toronto, where we did it's just a pilot, and this was in school, and it worked quite well. We were comparing the live vaccine to the inactivated vaccine, but we had a series of calls with the school board. So we really had to. You have to start early, and you have to get the school board. You have to go through a lot of permissions to get that done. But we were able to do that. But for the Hutterite colonies, no, we did that outside of the school.
I wondered what you learned about working with the Hutterite community in terms of building relationships, sustaining those partnerships. Were the people in the community able to participate, or do you feel benefit from this research? And because that was a big part, right?
No, that's a very important part and a very important question. So, no, we've had a great relationship with the Hutterite colonies, and a lot of it is our field staff, because the field staff develop close relationship with the Hutterite colonies. They go there, twice a week, and for years. So they've built very, very close bonds with the Hutterite community, and our staff have developed these great crossword. When you do a cohort or even a randomized controlled trial, you have to keep people engaged, and we create crossword puzzles that are geared to the Hutterite colonies in terms of what their interests are, and they very much look forward to that. And I go visit the Hutterite colonies, and they seem to like that. It's the closest I've ever come to being a rock star, because they go, "Oh, Dr. Loeb is coming." It's very funny, but it's a lot of fun. And I have to say, they're very good people, very, very honest, and very generous, right? Because they're doing this for, I think they derive benefit, but they realize that they give the rest of the world benefit in the knowledge that we derive.
Wow. Why don't you join me in thanking Matt again? It's fascinating how Mark is able to actually summarize a life's work in about 20 minutes because he made it appear simple. While in fact, many of us who've done research, we know how challenging it can be. Not only would you get those rejections from people not wanting to participate, when they do, that's when the difficult work begins. And we thank Mark again for really a fascinating talk, and most importantly for his dedication to finding solutions and always looking for the best ways to find those solutions, no matter the challenges that come along the way. And we're privileged that he's worked with many of the people here at St. Joe's in this work. This is Dr. Marek Smeja, who you also mentioned as one of his collaborators in this work. And many of you know Marek from his work as an infectious disease colleague here at St. Joe's. That's Dr. Stephen Walter, right in the middle, who also asked a question. I think it's St. Joe's. You said you were supposed to be McMaster, but we'd rather have him at St. Joe's. Yeah. Right. So, but like I said earlier on, one of the fantastic things about Mark is he's a great colleague to work with. Many of us have been the beneficiaries of his generosity in making things appear simple and teaching statisticians. Eleanor Pilinayegam, who is at SICKIDS, was one of our colleagues here in the biostatistics unit. So he's really been a friend of St. Joe's and a wonderful colleague to work with. And thanks again, Mark, for a fantastic talk. Right. All right, so once again, I would like to thank Anne for taking the time. Anne has work to do, by the way, but she always, every year, takes the time to come and be part of this celebration and representing the family. And every time she always, even stays, even after the presentation, to mingle with people. And we appreciate you always prioritizing this event for us, and thank you again. Right. All right, so, and really, we want to thank the family for continuing to support research at St. Joe's. And thank you, to Sarah and the foundation for always doing the best you can to support the mission of discovery here at St. Joe's. And finally, I want to thank all of you for taking the time to be part of this celebration. It means a lot, not only to the speaker to have people have interest or show interest in what they have to say, but also to us as a community, because that's really how we build a community that cares about generating evidence and using that evidence to solve problems. And we're grateful for you taking the time to be part of this event. All right. Now, we are hosting the reception outside. Please stay. There's going to be food, Laura, drinks. What else? Candy. That might be candy as well. Who knows? Yeah. So please do stay, and you're welcome to join us after the refreshments. And would I encourage Sarah, Ann, and Mark to stay behind so we can take some pictures afterwards. And once again, thanks to everyone for really being part of this celebration for this year. This is one of the highlights for the Research Institute. And like I said, Laura and Mike really make things happen. But I also have to acknowledge one colleague who's always really been the greatest supporters for the Research Institute, making sure that we look much better than we really are, is Sarah Howe. She's supposed to be on holiday and vacation, but she decided to come because this really means that much to her as well. And thank you, Sarah, for your leadership and always prioritizing everything about the Research Institute. Now, I'm not leaving anybody out. I always say, we at St. Joe's, we're lucky because we have created one of the best places to work. And part of it is because our foundational principle is health and humanity for all, because we truly, truly do care, not only about the patients we are privileged to provide care with, but we also care about each other. And Dr. Mark Loeb is really an example of really what it means to be caring about each other and about other people. And thank you all. I hope you have a wonderful reception afterwards, and look forward again to having everybody come again next year when we celebrate another recipient. Thank you.